Welcome to the second part of the cardiac defects presentation. These cardiac defects that we'll be going through here are going to be a little bit more serious. So these ones, depending on how severe each cardiac defect is going to be something that is going to be taken by a case-by-case basis. There are some kids that can have a very mild form of some of these, and there are other kids where they can have an extreme form. So this can vary from child to child or case to case. As always, just like I said in the previous presentation, the treatments and the therapies that they're doing for these are continually being developed and updated. So pay attention to those when you're out there. So I don't want you to focus as much about what exactly the treatment is, and usually it's some form of surgical repair, but I want you to focus more on what's going on and how would you treat it initially, or how would you treat this kid initially, and focus on the physiological things that are different. So that's going to help you think critically about these kids or what's going on rather than the procedures. So we'll talk a little bit about the procedures. Just understand the procedures can change from year to year. So let's go ahead and get started. So hypoplastic left heart syndrome, HLHS, that's what we're looking at here. This one's going to be a serious issue. We talked about this before. This is one that's going to be considered shunt dependent. So this one you're going to need to keep that patent ductus arteriosus open so you have perfusion through the systemic circulation. So this means the left side of the cardiac structure, including the mitral valve, the left ventricle especially, and the aortic valve and the aortic arch have an abnormal development. So like I said before, some kids can have a very mild form of this. Other kids, they have a very severe form of this. If it involves the hypoplasia of the left ventricle is that workhorse of the heart, right? That's the one that's supposed to squeeze it to the brain, the rest of the body. This is going to be very serious if it involves the hypoplasia, so the very small left ventricle. Not a good thing here, right? If it has an atresia or stenosis of the aortic and mitral valves and hypoplasia, that can really affect the ascending aorta and the aortic arch and really impact the ability to perfuse the rest of the body. And that's going to be a major system shutdown. So we need to keep systemic blood flow going. So to maintain systemic blood flow, we need to bypass through the foramen ovale and the right atrium, and as well as keep the ductus arteriosus open. So we'll talk about that here in a second. You're going to have oxygenated blood that mixes with deoxygenated blood. So that's a left to right shunt on the right side. So remember, the pressure is higher on the left side of the heart than on the right side of the heart post-birth. So this is oxygenated blood mixing with deoxygenated blood that goes to the right side of the heart before it goes to the pulmonary artery. There's so much back pressure from the systemic circulation that it's a left to right shunt, which is not terrible, but we do have to be considerate that a lot of this blood will go to the pulmonary artery, and therefore a lot of that blood will then go to the pulmonary circulation, which then can cause pulmonary edema, right? Remember, that's one of the things we need to be concerned with a left to right shunt, is that pulmonary edema. So this can cause a left to right shunt. When it goes to the pulmonary artery, it has two options. It could either go to the lungs, right, to the pulmonary circulation, or it could travel through the ductus arteriosus. It's got to make that choice. So if we have our pulmonary artery, right, going on, and we have our aorta that's going on here, and we'll just do the ductus arteriosus. This is green. When blood comes up into the pulmonary artery, it's got to make its choice. Either it's going to go to the left and right lung, or it's going to go through the ductus arteriosus, right? So it's got to make that choice. When it goes through the ductus arteriosus, this may be their only way to perfuse blood to the rest of their body. because if that left ventricle, remember that left ventricle is just not formed. So here's the classic square heart. That left ventricle here, if it's hypoplastic, right, very poorly formed, especially if there's no valves hardly there, they're not going to be able to squeeze anything into their aorta. And remember, we talked about the aorta possibly being narrowed, stenosed, right? So their ability to flow blood through their aorta is going to be severely impacted, so that we're going to have a hard time getting systemic blood flow. So how do we get systemic blood flow that's oxygenated? Well, remember, your pulmonary veins drop oxygenated blood into your left atria. So here are your pulmonary veins dropping this really good oxygen into your left atria. Well, as long as we have a foramen ovale that is open, this then oxygenated blood can then flow into the right atria, which then goes to the right ventricle, which this now slightly oxygenated blood, because now it's mixed with deoxygenated blood, of course, this mixed blood then travels through the pulmonary artery, and then hopefully some of this oxygenated blood, this mixed blood, will make its way through systemic circulation. I hope that sort of makes sense. That's the best animation I can do currently, but that's sort of what we're looking at here. Is we need that patent foramen ovale as well as that ductus arteriosus. Both of those need to be open in order to have oxygenated systemic circulation, especially if we're having a severe issue with our aorta going on, as well as the hypoplastic portion of the heart and the valves as well. That's going to be very serious that we keep those open. This syndrome is more common in males than females, with a 55 to 70% more prominence. Jeez. All right, moving on. Pathophysiology. The pulmonary artery supplies both systemic and pulmonary circulation. That was that drawing I was just trying to do for you guys, right? So it has that option of systemic going to the lungs or going through the arteriosus, ductus arteriosus, to the rest of the body. So it's critical that you keep that shunt open. So would using high FiO2s be a great option on this baby? Absolutely not, right? FiO2s, remember, once you increase that PaO2, that starts letting them close down that ductus arteriosus. So we have to make sure we keep that arteriosus open. So when we get to treatments, we'll talk about prostaglandins and other things we can do to keep those shunts going. Pulmonary artery is supplying both systemic and pulmonary circulation. So the pulmonary artery is doing the balance of the workload. Circulations are said to be in parallel. So that means the vascular bed is determined by the balance of systemic vascular resistance, PVR, and SVR, right? Pulmonary vascular resistance and systemic vascular resistance. So let me ask you this. All right, so let's draw our pulmonary artery again, and our aorta, and then we'll do green for the ductus arteriosus again. Okay, so what happens if we increase systemic vascular resistance? In other words, let's say we increase systemic vascular resistance, and by giving this baby epinephrine, or a vasopressor of some sort, and we vasoconstrict this baby. So now there's more pressure in systemic vascular resistance. So when blood goes to the pulmonary artery and there's less pressure in the lungs, less pulmonary vascular pressure than systemic pressure, where's the blood going to go? Well, fluid goes the path of least resistance. So in this case, we're going to actually have more blood flow to the lungs than we are that's going to flow to the rest of the body. So what would happen to this baby's systemic blood pressure, or perfusion to their kidneys, perfusion to their brain, perfusion to, the rest of their organs? It would go down, right? So we can't increase SVR too much. What about PVR? Well, if we increase pulmonary vascular resistance, let's say they're hypoxic, let's say they're acidotic, right? Those are all classic things that are pulmonary vasoconstrictors, right? So this baby's acidotic and severely hypoxic. Well, now we're going to have a higher PVR than an SVR. So then if that PVR is higher than SVR, so if we have more pulmonary resistance than systemic vascular resistance, then this blood's going to go the path of least resistance and go systemically. So we need to balance, is what it's saying, balance the PVR and the SVR. This is a very delicate dance that we'll play. So this means we might do things like nitric for PVR play, right, to increase or decrease. We could also use acidosis, right? Permissive hypercarbia, running lower PO2s. Obviously, we're going to be doing that anyway because of the ductus arteriosus. So this becomes a delicate balance here, a delicate dance. And so I hope you understand the complexity of this, but that you understand that we can't have one that supersedes the other. PVR, so pulmonary vascular resistance, needs to be in direct balance with SVR if we're really going to make sure this kid is going to be doing okay. Because if PVR has, if we have a low PVR and a high SVR, that means most of that blood is going to go to the lungs, pulmonary edema. Hardly anything's going to go to the arterial system and go and perfuse the organs, so then they start going into organ failure. Well, if this tips the other way, where we have PVR that's higher than SVR, then we're going to have good blood pressure. However, we're not going to send hardly as much blood to the lungs to pick up oxygenated blood, to send it to the left atria, to send it then to the right atria, to then send it to the pulmonary artery, to then hopefully send it through the system, right? So we got to have this balance. We can't have one superseding the other. Hopefully I've made that point sort of clear there, right? So we need a non-restrictive atrial septal connection. In other words, the opening in between the left and the right atria needs to be there, right? We need a good, decent opening in between the atria. So that way we can send this oxygenated blood that's coming from these pulmonary veins, we could send it over and ultimately send it out to the lungs, right? Then could go through the ductus arteriosus, and then go to the rest of the body. That's a lot of stuff, but hopefully you're starting to catch on to this. Coarctation of the aorta is very common in this, and it just does vary and depend on baby by baby case, right? Where the coarctation is. Let me ask you this, is this cyanotic or acyanotic? You tell me. I love that stuff. All right, so we can talk about that on one of our meetings. You probably have seen the answer in your book as well. I encourage you to read the chapter much more thorough than what I can explain here. But understand here the big thing, you not only need the ductus arteriosus to stay patent, but we also need the foramen ovale. We need that opening between the left and right atria if this baby's going to be able to get any oxygenated blood to the rest of their body. What are some signs and symptoms? How would you know this kid has it? Well, there are three things that you're looking at here. Usually shortly after birth, all right? So what happens when that PDA starts to close and that foramen ovale starts to close? Well, that's when you would start to see hypoperfusion, right? So this is that bullet point that I'm talking about here. If the ductus closes, you're going to see low blood pressure. You're going to see a metabolic acidosis because now their body isn't delivering oxygen to their tissues, so they're creating a lactic acid. So this would be a gap acidosis, gap metabolic acidosis. Circulatory collapse can occur rapidly. In other words, their blood pressure would just drop drastically. They would turn pale, dusky, and obviously that would lead to a demise ultimately. So it can happen pretty darn fast. So most of the time, this is often diagnosed prenatally, so before the kid ever comes out, or shortly after birth, right? These guys, the big thing here is to make sure that that foramen ovale is unrestricted. In other words, we have good communication between the right and left atria, good communication in the PDA. At birth, normally when you're born, remember we talked about this before, as you're in utero, your PVR is very, very high. Then when you start breathing, it expands all those capillaries, right? And then it reduces pulmonary vascular resistance. That's part of what changes the pressure being high on the right to now the pressure being high on the left. So that's that normal change. With the drop in PVR that occurs within those first days of life, pulmonary blood flow increases at the expense of systemic blood flow. So what would happen to the blood flow to their legs, to their kidneys, things like that? Well, that would start to decrease. They would have cold, pale hands and feet and legs, especially. This continues, they'll develop a metabolic acidosis. So this is for those babies that aren't as, there's still those communications open, but it's not as severe with those hypoplastic symptoms. So this is usually where we're going to develop when they have this metabolic acidosis that develops because they are not getting oxygen to the tissues. The tissues are producing lactic acid. Just like you going out and run 20 wind sprints in a row right now as hard and as fast as you can, you're going to build up that lactic acid. There's lack of oxygen going to your muscles. They're developing that lactic acid, right? It's anaerobic. Right, so because of this, this is going to develop what's ultimately known as pulmonary overcirculation with these kids. This is not good either, right? They're going to need to correct this ultimately. So what are some things that you'll see on these kids? Obviously, they're going to be cold. We talked about that with low perfusion. Tachycardia, they're trying to make up for a cardiac output, right? So their left ventricle is non-functional here. So what are the two components of cardiac output? Remember, it's stroke volume, which is like your pulse pressure, times heart rate, which equals cardiac output. So when you're looking at this, obviously these kids are going to be running a little bit tacky compared to us. Obviously respiratory distress, what happens to all that blood flow that's going to their lungs? Well, they got excess blood flow going to the lungs, especially if they got systemic, a high systemic vascular resistance. So they can develop pulmonary edema, respiratory distress pretty easily. Cyanosis and pallor, very, very common with this in the more severe forms, obviously. Poor perfusion, weak pulses in the extremities and in the neck. Hepatosplenomegaly, that's very large, and a loud S2, that's the pulmonic valve shutting. So what's the prognosis? Before the early 1980s, so this is going back a little while ago, their outcomes were pretty poor, but now they developed the Norwood procedure, which does stages of different things that ultimately turns their ultimately what everything does here is they're going to eventually connect. So here's the pulmonary artery. They're going to ultimately connect the superior and inferior vena cava to the pulmonary artery. So they're going to bypass the right ventricle altogether with the vena cava. So they're going to dump all deoxygenated blood, will passively dump into the pulmonary artery. I know this sounds weird, but that's what they'll do. Dumps into the pulmonary artery, so you have passive filling of the pulmonary artery. You're not using the ventricle at all. And then they're going to turn the pulmonary veins, they're going to connect those to the right side of the heart, and then they're going to dump oxygenated blood into the right side of the heart and to the right ventricle, which then the right ventricle will be connected to the aorta, and then the right ventricle is eventually what turns into what pumps the blood to your brain and the rest of your body. So they'll actually switch the roles of the ventricles. The right ventricle no longer pumps blood to the lungs. They're going to just bypass that altogether by connecting the inferior vena cava and the superior vena cava directly to the pulmonary artery. Isn't that crazy? And then they'll turn the right ventricle into ultimately the function of the left ventricle. So these are the procedures. I'm not going to test you extensively on the procedure, like I said. right? So these procedures contributed to a lot better outcomes on these patients when they started to do this. Like I said, classically, these patients undergo 3 stages of surgery. That's a sputum bowl question. They always ask that. A lot of this takes a big balance between systemic and pulmonary blood flow. Remember, this is that PVR, SVR, balance beam that we have to play with, right? One can't be stronger than the other. So we might have to give this kid epi. If their SVR is too low and their PVR is high, we might have to give them epi to sort of balance this equation out, right? So there's just these little balances that we have to play here and there. So understanding your cardiac and hemodynamics is going to be crucial with these children. That should go without saying. All right, what's the best way to diagnose this? Of course, you probably already guessed this. The echo is going to be like the best way to do it. Now, as you're looking at this echo here, you'll see, okay, here's the right atrium, left atrium, right ventricle, and you see this little star here? This area is the left ventricle, right? Obviously, it's inadequate to squeeze blood. Do you see the huge gaping hole in between the left and the right atria? That's important, right? We need that to dump oxygenated blood from the lungs into the right atrium so we can send it to the right ventricle, so then we could send it to the pulmonary artery, which then via the ductus arteriosus we can send it to the aorta, and then they can have blood pressure and blood flow to the rest of their body. Isn't that crazy? Hopefully all that makes sense. I know it looks like a John Madden drawing, but that's the best I can do. So echocardiogram is going to be one of the best things you can do. Hopefully that picture, that echo picture, helps make a little bit more sense of the situation. EKG, obviously, sinus tach, right axis is always a sign of pulmonary stress. But in this case, which side of the heart has more electrical activity? Which side has more? So it's obviously going to be the right side. Right atrial enlargement obviously can go along with this, because who's doing the bulk of the work, the left atria or the right atria? There's much more volume because the right atria has not only the venous blood flow dumping into it, but now also the oxygenated blood flow from the lungs. So now the right atria has got to double its capacity and double its workload, obviously. So you're going to have right atrial and right ventricular hypertrophy with this. So it would be a right axis deviation if you were to do a 12 lead on this kid. Pulmonary vascular markings, usually you can see this on the x-ray. That's because of the excess pulmonary blood flow, especially if their SVR is high. They're going to be sending extra volume to their lungs, and that's where you get that pulmonary edema. All right, treatment. Oh heavens. All right, so just stick with me here. Don't dive in too deep here. Prostaglandins to keep the shunt open, right? Should be given immediately, right? To keep that ductus arteriosus open. Right. If we have the absence of blood flow across the septum, they can do a thing like a balloon procedure where they just open up that communication between the two. But we need to make sure there's open communication between the two, right? We talked about that. Not only do we need to have the PDA, we also need a communication between the atria if we're going to send any oxygenated blood to the rest of the body. Right? Minimize the amount of oxygen should help as well. So a lot of times they just use room air, which, hey, guess what? When you're doing NRP, you have the option of doing room air 30%, right? So room air is a good place to start. Every once in a while, if we need to increase PVR, right? If we need to increase PVR, remember hypoxemia causes pulmonary vascular resistance to increase. That's why almost all your lung diseases back in disease class had an increased pulmonary vascular resistance. Hypoxemia and acidosis cause pulmonary vasoconstriction. So if we give an FiO2 that's 0.17 instead of 0.21, then that would cause an increase in our PVR because that would cause that pulmonary hypoxia, right? So usually we're going to target their FiO2 between 17% and room air. That's right, sub-ambient FiO2s. Subambient FiO2s. So that's where you're mixing it with either a nitrogen tank, which is what we classically seen was the nitrogen. So you would have an oxygen analyzer, and you'd see the oxygen analyzer at 0.17, which would be subatmospheric or subambient, sorry, subatmospheric. It's a whole different thing. Subambient oxygen, in order to keep their systemic saturations around 70-80%. That's your goal saturation. This is your goal. Saturation for these kids is 70 to 80%. So you're just getting something that's survivable. You're not getting what's normal. You're just giving their body what they can survive on until we get them into a more stable place with their physiology. So hypercarbia can also be used. So not only could we use subambient oxygen, we can also use or employ hypercarbia, right? So this is like what we have with our patients that we do permissive hypercarbia on that are in severe ARDS, right? So what happens to a patient's pulmonary vascular resistance when we have high CO2 levels? Well, it increases it. It constricts the pulmonary capillaries. Remember, pulmonary capillaries it constricts. So hypercarbia constricts pulmonary capillaries, which will then elevate pulmonary vascular resistance, right? We're squeezing the hose. We're making those blood vessels smaller. So if we let the baby develop a little bit of permissive hypercarbia or hypercapnia, whichever term you like to use, that could also help balance the PVR-SVR relationship. So ventilation with deep sedation, NMBAs, right, neuromuscular blockades, may allow us to control CO2s a little bit better as well. Ventilating in a mild respiratory acidosis, right, in addition to hypoventilation, may increase by adding CO2 to the gas, right? And so in this presentation, towards the end of it, I have a slide that shows how they would add CO2. So that is another option out there. Have I ever done it? No, but it is an option that's out there. So pay attention to where you're working, what they expect of you. Make sure you're comfortable with those procedures as well if you're going to be working in a place where you are doing that. IV vasodilators may decrease systemic vascular resistance as well. So if we have a high SVR and hardly any blood is going to their kidneys or anything like that, we may have to give them a vasodilator to allow for their blood pressure to actually increase. I know that sounds opposite, but hear me out here. When you give a vasodilator in this situation, you're going to decrease systemic vascular resistance, which means the path for the blood to flow then becomes more simply to flow through the systemic circulation rather than the pulmonary circulation. So in this situation, by giving a systemic vasodilator, you actually improve perfusion. Isn't that crazy? Oh, I just thought it was fun. A little weird fact. Hey, it does the opposite normally, but now we're going to use it to actually improve perfusion. So in this case, if SVR then is lower than PVR, which is what would happen with a vasodilator, an IV vasodilator, then that would help us get more blood flow to the rest of the body. They can also improve blood flow altogether by, hey, transfusion, right? Try to get a good hemoglobin and decrease blood flow by increasing blood flow viscosity. Remember, the pulmonary capillaries are thinner, right? Your AC membrane, right? The capillary at your alveolar capillary membrane is thinner than a piece of paper, right? Take a piece of paper, look at how thin it is. Thinner than that is what your pulmonary capillary is. So if we make the blood thick, if we increase blood viscosity, where's the path of least resistance? Through the ductus arteriosus or to the lungs, where they got to go through that very tiny opening, right? Very tiny small capillary. Well, if we give more blood viscosity, then more blood's going to flow systemically. Isn't this crazy? I love this stuff. All right, treatment. The Norwood procedure is going to be one of it. The Norwood procedure itself reconstructs the aorta. And they're going to add a shunt, which is great because that provides pulmonary blood flow, right? The pulmonary artery bands can also be used, right, which can improve pulmonary vascular resistance. So what's the advantage of putting a pulmonary artery band? Well, remember those like gastric procedures where they put the gastric band? If they do a pulmonary artery band, it restricts blood flow, or over here, sorry. It restricts blood flow to the lungs right here. So then if we restrict blood flow to the lungs, then more blood could then be pushed through the ductus arteriosus into the aorta for systemic circulation. So the path of least resistance, if they do pulmonary artery banding, is then going to be sending most of that blood through the ductus arteriosus, which then would go to the rest of the body. Pretty crazy stuff. There's a hybrid of pulmonary artery banding and doing a catheter that stents the ductus arteriosus open. So this can be used as well. Like I said, don't pay too much attention to this part. Understand more the physiology and why they're shunt dependent. All right, so this is just a simple thing. I took this straight out of your book. This sort of shows where they would go. You have the classic where they have to go on bypass, or they have the Norwood Sano, which is more updated, where they can go to the Glennon, which then at 4 to 6 months, they can go to the Fontaine, which is done at 2 years old. So this is that whole 3 procedure type situation. They can go to bypass, the hybrid procedure, go to bypass, then eventually go to the Glennon, and then the Fontaine. But there are other options too. They could hope for a heart transplant, or there's always the other option there of comfort care. So these are sort of different things. Do I want you to memorize this whole procedure? It's very complex, not for my purposes. If you intend to work in this field, you need to know all what the current stuff is here, but I'm not going to force you to do it in this course because things change. All right, so this is what they're looking at doing here. I love these pictures. They sort of subvert the pulmonary artery. They take the aorta, right, and you see the aorta where they attach it to the pulmonary artery, right, and you see the pulmonary artery. They're going to attach that shunt over there, which attaches it as well. So they're turning ultimately the pulmonary artery gets venous return directly, and the right ventricle ultimately turns into what pumps blood to the rest of the body through the aorta. Pretty crazy stuff there, but there you go. So these are all just pictures from your book that show pretty much the same thing. They're dumping, they're putting the aorta in there, they're putting that patch in there, and then they're turning that right ventricle into the new left ventricle, and then they're going to attach all the vena cavas to the pulmonary artery. So management after procedure, these kids can be pretty tenuous. The low cardiac output syndrome, arrhythmias can easily go on with these kids. Some of these kids obviously will need mechanical ventilation, because what happens with the lung compliance, especially when you have pulmonary edema, it's going to go down, right? Because they have to balance that sort of flow. So a limited myocardial reserve, in other words, they can't take a lot of heart stress. So the big thing here is balancing pulmonary and systemic blood flow. So that's going to be your SVR and your PVR, right? And that's that whole balance act that you got to make. You cannot have one that supersedes the other. You cannot have one that's higher than the other. And if you do, you're going to hurt the kid, right? So they got to play it. So that's why you might have to do things with PVR like an acidosis or hypoxemia or adding CO2 to their ventilator, right? Or SVR, you might have to give a vasodilator just so that their SVR goes down, so that way more blood can flow systemically. So that way you can perfuse their kidneys and the rest of their body and keep their systems flowing, right? The goal here is going to be the rule of 40s. This one is something I want you to remember. The rule of 40s targets a PO2 of 40 millimeters of mercury and a CO2 of, you guessed it, 40 millimeters of mercury. So this isn't using the hypercarbic method yet. We're not using the acidosis. Those are only if we need to increase PVR, right? So if blood pressure is low, we need to increase PVR is the short and sweet term, all right? So that's when you might consider either adding CO2 to the circuit, decreasing their vent settings, right? So that way they have a higher CO2. But the whole thing here is you need to keep that PO2 around the 40s, and you need to keep the CO2 around the 40s. And the whole idea here is you need to still ventilate to provide adequate gas exchange or survivable gas exchange, right? A survivable acid-base balance. Now, notice I didn't say normal acid-base balance. I said survivable acid-base balance. The PO2 needs to be in the 40s because if it gets too high, what happens to that ductus arteriosus? Correct. That ductus arteriosus will start to close. So any manipulation of the tubes or anything like that, you need to be careful. These patients are very tenuous. Even suctioning or retaping, they can get hypotension because what happens with anxiety? You get that fight or flight response and you vasoconstrict, right? And then therefore your SVR increases. Well, then all that blood just shunts to most of that blood just will then flow into their lungs. Systemic blood pressure is low and they'll check out. They'll go to a bradycardia, right? Because all that increased, or if you have something that increases PVR, like they develop a severe acidosis, they develop a hypercarbia that's more than what you were initially planning on these patients. You're going to have good blood pressure. However, your oxygenation is going to dump. They're not going to be in that 70 to 80% goal area anymore. They might be in the 60s, 50s, because now not as much oxygen is flowing to the lungs to pick up oxygen and to get rid of CO2. Whew. Isn't that crazy? A lot of stuff here going on. The Glennon procedure, you're going to see this a lot. This is where we have the stage 2 surgery. We talked about that. That was in that flow chart that we looked at just a little bit ago. Big thing to remember here, and this is the highlight for respiratory therapy, is positive pressure ventilation, that's us, can negatively affect pulmonary blood flow. Well, remember, we increase intrathoracic pressure with positive pressure ventilation. So here are your lungs. Here is your thoracic cage, right? And if we give positive pressure breaths, it's supposed to be little plus signs, right? If we have someone on positive pressure ventilation, the lungs, right, expand, right? So that's the whole idea. You're giving a breath, the lungs should expand. You're like, this sounds great, that sounds good. However, what else is in the chest wall besides the lungs? Well, you got this like 4-pound structure over here called the heart. And then you also got this like vena cava thing, superior and inferior vena cava thing that's going on. So if we increase intrathoracic pressure too much with positive pressure ventilation, we're going to impede venous return, for one, and also we can squeeze the heart and put more myocardial stress there as well. So that whole part there where it says positive pressure ventilation may negatively affect pulmonary blood flow, it is correct. If we use too high pressures or too high of intrathoracic pressure with our breaths, then that can easily impede pulmonary blood flow and therefore cause a more metabolic acidosis, therefore cause multi-organ system failure, and so on and so forth, right? So the sooner we get this person safely extubated, right? That's the key word there. Safely extubated, that resumes negative breathing, right? That's the whole idea there. Negative breathing actually improves cardiac and pulmonary blood flow, because when you're using negative pressure from the thoracic space, right, for negative pressure breathing, that's going to pull the atria open. It pulls the vena cavas open and allows for more preload. So your hemodynamics are going to be better off the ventilator than they would on the ventilator. Hopefully that makes sense. If not, I will do a separate adult cardiac lecture for you guys. All right, so this is what you're looking at here, is they're ultimately taking that right atrium, they're going to the pulmonary artery, they're bypassing the right ventricle altogether. All right, so hopefully you got the basics of hypoplastic left heart syndrome. A lot of complexity in there, but try to go through and understand the physiology. If you understand the physiology of what's going on and why they need their shunts open, and how tenuous PVR and SVR are, and what are some of your strategies as the respiratory therapist to increase PVR? What is a strategy to decrease SVR, right? These are all things that you should keep in mind here. TAPVR, total anomalous pulmonary venous return, also known as total anomalous pulmonary venous connection as well. So we'll talk about this one. This means the pulmonary veins that return to the left atrium are returning to components of systemic venous circulation rather than the left atrium. So instead of going to their normal place, they go somewhere else, and they're going to venous circulation. So they're not going to arterial, they're going to venous. Isn't that crazy? So an atrial defect is very common in these. It's more important in left ventricular output, both in the fetal and newborn circulations. So pathophysiology here, the left to right shunt. So if this is a left to right shunt from the pulmonary veins, what is a cyanotic or acyanotic? Since we've already talked about this in the other lecture, you tell me. I love that stuff. All right, left to right shunt, pulmonary veins to the right side of the heart. So we have good blood, right? Good blood going to the bad side, right? That's what we see going on in this picture over here, right? Good blood going to the bad side. Pulmonary and systemic venous flow to the right atrial, right ventricle, and volume overloaded develops in these patients. So you're going to have a lot of pulmonary blood flow going on ultimately, right? Because it's dumping into that left side, or dumping, instead of going to the left side of the heart, a lot of it's dumping to the right side of the heart, which means we got a lot more volume going on in the right side of the heart. So signs and symptoms that a kid might have: total anomalous venous return. Symptoms are more similar to very large ASDs. So remember the ASDs where it was just the opening in between the left and right atria? That was it. So not a whole ton of symptoms there. A lot of these kids will just be more of your failure to thrive. They'll have a lot of respiratory work of breathing. That's what it's talking about here, respiratory effort. With activity. So it's sort of like those people that have exercise-induced asthma, or people with COPD or chronic lungs issues, where they're fine at rest, but when they get up to move around, that's when they get short of breath. That's what it's going to look like here. Physical exam, they might have a higher right ventricular volume when they're looking at these kids, ventricular impulse. In other words, they would have a right axis deviation on their EKG. Their heart sounds might sound a little bit different than normal, so that might be an indication an echo and a 12 lead might be in place. More likely they'll do the echo than the 12 lead, but usually that murmur or anything like that, they'll want to do some more testing with it, hopefully. Diagnosing, a chest x-ray should show a normal heart size, hazy ground glass appearance. So is that specific to TAPVR? It is not. Which one of these would show TAPVR? Echo, right? The echocardiogram would probably be your best one. Cardiac MRI would be also a good option. Remember, with infants, though, usually you have to go under general anesthesia for an MRI procedure, so that's a little bit more risk there than an echo. A lot of infants with undiagnosed TAPVR are thought to have just pulmonary hypertension, premature pulmonary hypertension in the neonate. And so they'll get therapy for that. They'll get either a little bit of hyperventilation or hyperoxygenation. Like I said, on a term kid, you don't have the risk of oxidative injury like you do on a preterm kid. So we can give them higher FiO2s without worrying about things like retinopathy or prematurity. Or we can give them nitric, right? Inhaled nitric oxide, sildenafil. Sildenafil is a vasodilator. Sildenafil, remember, is the different term for Viagra, and that's that vasodilator that'll help with that as well. So these kids usually are thought to have pulmonary hypertension, and then they're given treatment for their pulmonary hypertension usually. Usually these will increase blood flow, that's the whole point. But what will happen in this case? It'll make the TAPVR worse, because what happens to PVR? Well, pulmonary vascular resistance decreases. Remember, our pulmonary vascular resistance will go down if we give a pulmonary vasodilator, right? It's just like going from a 2-lane highway to a 4-lane highway. Just a lot more space, a lot less pressure against the cars around you, right? So this would make it worse because now there's less pressure in the venous side than there is on the arterial side. So even more blood will come over and less blood will go to the arterial side. So you're actually going to make things worse. So if you know that it is TAPVR, do not do these, right? Do not give the pulmonary vasodilators. Do not do any of that stuff, right? However, let's say you don't know and you're the one administering nitric. You're the one changing vent settings and you start to see this kid's blood pressure go down. Like I said, you start to see this kid's blood pressure start to drop with adding nitric or anything like that. Stop it. Because odds are you might have one of these type of situations going on, either shunt dependent or something like TAPVR, right? Where you have to make that change, you have to stop it because it's making the kid worse, right? So obviously you would stop the nitric or you would stop whatever therapy that is, right? So you might have to manage these kids differently with the ventilator. The thing here, because you have extra pulmonary blood flow and you're causing pulmonary edema, might be giving them that extra positive end expiratory pressure using higher mean airway pressures, right? So I'm just going to put high mean airway pressures. Not just PEEP, but PEEP does increase your MAP, right? Your mean airway pressure. So we do that because the capillary, if we have more distending pressure inside the alveoli compared to the capillary, that helps reduce the pressure gradient, okay? So in here we have tons of blood that wants to come out, tons and tons of blood that wants to come out, but we're not going to be able to do that as easily if we have an increase in alveolar pressure, right? So the more distending pressure we have there, the better chance we have at avoiding pulmonary edema from getting worse. So it doesn't reverse or stop necessarily the pulmonary edema. It just helps mitigate the pulmonary edema more than anything until their lymphatics in the loose space and things like that can reabsorb it. All right, unobstructed TAPVR often presents later in infancy, so more kids that will have like a CHF type thing going on, failure to thrive, they won't eat well, they won't grow real well, and that's the real thing, is that growth curve that they watch on babies. So that's the big thing that they'll be looking at here, and that's because they have that left to right shunt. Their body, their muscles, all those things aren't getting as much blood flow and perfusion and nutrients as they normally would, and that's what's going to cause a lot of those results. So if it's a significant obstruction, usually they're going to have a profound hypoxemia and acidosis. So this can be one of those things where they don't catch it till they're well out of the hospital, or if it's severe enough, you're going to see it pretty soon, right? It's profound hypoxemia and acidosis, especially if you initiate a procedure that does reduce PVR and they start dropping their blood pressure. So treatment, obviously, if it's a severe obstruction, it's going to be an emergency, right? So what they're going to do is a surgery. Hopefully that should correct the things. But if they're too unstable for the surgery, right? Obviously, mechanical ventilation with PEEP for pulmonary edema is going to be your big thing here. So using elevated mean airway pressures will be a friend of this patient. They might have to do an atrial cystectomy, right? So when you're looking at here, when you're looking at this, you're going to have to look at the blood flow. And that's what they're going to do is they're redirecting that pulmonary venous blood flow, hopefully to where it was supposed to go in that left atrium. That's where it was supposed to be in the first place. But what you have to look at here, they might have to wait till this kid's stable enough. Obviously, these kids are going to have a lot of pulmonary congestion, which decreases lung compliance, which makes it harder to also oxygenate these kids because now you not only have atelectasis with poor lung compliance, but now you have less surface area to diffuse oxygen as well as CO2 across. So you see how this can be very complex in some of these kids. So obviously that lung compliance would get worse. And their oxygenation, they would have a higher PF ratio, things like that. Okay, tetralogy of Fallot. Tetralogy of Fallot is a common congenital heart abnormality. So there are 4 components. That's the tetralogy part of it. There are 4 components. You do need to have these components memorized. And guess what? If there's a picture on the exam of the square hearts, right? This is why I wanted you to do the assignment where it's like, look up a picture of this. And this is why your books have pictures of these as well. I want you to be able to identify some of these cardiac anomalies, right? What's different about this, right? So if you see a very skinny pulmonary artery, if you see a VSD, I don't want you answering, hey, this is a VSD and move on. I want you looking at the whole heart. And I want you to look, hey, is there more than one thing going on? If I see a coarctation, right, that's probably the only thing going on. If I see pulmonary artery stenosis, well, that could be part of a couple of things. That could be either by itself or it could be part of a tetralogy of Fallot. A VSD can happen by itself or it could be part of the tetralogy of Fallot. So look carefully. So in tetralogy of Fallot, they have these 4 components. They have a VSD, pulmonary artery stenosis, which is a very significant thing here, an overriding aorta, which we'll talk about this. It's on the right side usually, and then the right side has more hypertrophy on it as well. So more stenosis in the right usually means it's a right to left shunt. A right to left shunt. Tell me about a right to left shunt, which means it causes cyanosis. So let me ask you, cyanotic or acyanotic? All right, so this is the picture here. Here we have a stenotic pulmonary valve. And we also have, oh, that's a blurry picture. We have a stenosis pulmonary valve. So that means we have more, if we have a stenosis in a pulmonary valve, then we have an increase in pulmonary vascular resistance. And so that means we'll have bad blood. Since blood won't want to go through the pulmonary artery, blood's going to shunt, right? It's going to be causing a right to left shunt. Through the VSD ultimately on these kids because the right side of the heart is getting a lot of blood flow, blood volume. It's going to have hypertrophy. That's where you're going to see that as well. Let's look at some better pictures later on. At birth, some of these kids may be mildly cyanotic, and that's just them with the ductus arteriosus. So that's just them sort of at birth being okay. But once that ductus arteriosus constricts, once that ductus arteriosus closes off, that's when they become cyanotic. So when that ductus arteriosus finally closes off, that's when it can happen. So this is a delayed action from birth. So in other words, you won't be in the delivery room and see this usually. This is something that happens after you're gone after you've charted on it, right? So in this case, infants that have pulmonary atresia, right, where that is there, or severe pulmonary stenosis, are then dependent on the ductus arteriosus. In other words, you might have to do things that then reopen that pulmonary communication, that communication in between the aorta and the pulmonary artery, the ductus arteriosus, right? So in this case, this can be definitely cyanotic, and it might be shunt dependent as well. This is what you're looking at. You have that VSD. This is a much better picture here. Blood flowing in. And then you have that VSD. And then here's the overriding aorta. See how the aorta is not on the left side, but usually is more on the right side? That's what you're looking at here. And here you have that mix of blood coming in from the left atria and the left ventricle. And then also you're going to have that mix of blood here. Do you see how skinny this pulmonary artery is? Do you see that? How skinny that is? So that PVR is incredibly high. So are you going to be sending a lot of blood to your lungs? No. Are the aorta? So a lot of the times here, it's getting that pulmonary valve to open up, or getting a bigger pulmonary artery opening is what's going to be the big thing with a lot of these kids. So signs and symptoms, they might be mildly cyanotic, but once that ductus arteriosus closes, that's when things change. All right, so changes in systemic vascular resistance changes pulmonary vascular resistance. We've already talked about that. And they might have what's called a TET spell. Well, what's a TET spell? Well, that's what this whole section is here. They're going to have deep breathing. They're going to be unconsolable. They're going to have a cyanosis period. They'll faint for almost no reason. So that tetralogy or TET spell is what you might see in these kids. Decreased pulmonary blood flow and result in cyanosis because of the increase in PVR, which may lead to even more right to left shunting, right? Because if they're cyanotic, they're pulmonary vasoconstricting, which increases PVR, right? Remember that increases PVR. That will then increase the amount of blood going from the right side that's deoxygenated through the VSD to the aorta and cause even more cyanosis, which then cyanosis will make the PVR even higher again. Do you see this vicious cycle of getting worse? So this is that vicious cycle of hypoxemia, and that's what you're trying to avoid. So the idea here is, how severe is this on this kid? Well, it depends on how bad their their pulmonary artery obstruction is. So that's what we're looking at, is how bad is that pulmonary artery restriction. So when we're looking at this, they might have that murmur that says, hey, they have some stenosis there, and it's very mild, and the kid has very mild TET spells. It's something they may not even be able to detect very well. Usually these babies will have what's called a boot-shaped heart, and I don't know if I have an x-ray on here or not. But that's the result of that extra backflow from more of a significant right ventricular outflow tract obstruction. So that's what that stands for, right ventricular outflow tract, which would then lead to right ventricular hypertrophy, which is part of the 4 things you would see. So expect me to ask you, what are the 4 things you would see here? How do you diagnose this? Obviously, echocardiogram would be very, very helpful here. X-ray, just vascular markings, which means you would have to follow up. Cardiac MRI, which would require anesthesia. Cardiac cath lab can also be used, which would also require some form of anesthesia as well. Treatment, prostaglandins, of course, right, to keep the ductal patency, right, until surgery or the cath lab can be performed. That's the other one. What's something you can do at the bedside is what I heard you ask. What about this knee to chest position? Well, that will increase SVR and promotes blood flow to the right ventricle. Then more blood flow can get to the pulmonary artery. We're back pressuring the system. We're kinking off the end of the hose to back pressure the side part of the hose, right? Morphine can also do help with the irritability and cause pulmonary dilation. You got to watch out though, because morphine in higher doses can decrease systemic blood pressure too. Oxygen, obviously oxygen reduces PVR. That should help with oxygenation if we reduce PVR in this case. So in this case, if you give nitric oxide, a pulmonary vasodilator, that could actually help this kid. In this case, hypoplastic left heart, not helpful, right? Beta blockers, you can also use that relaxes the pulmonary artery. The right ventricular outflow tract is an AKA or a synonym for that. Systemic vasoconstrictors, that will increase SVR, which then back pressures pulmonary blood flow. So pulmonary blood flow will be then, pulmonary vascular resistance would then be lower than systemic vascular resistance. Bicarb can also be used to help treat mild acidosis here and decrease PVR. All right, so a lot of these kids will usually get a repair before they're a year old. Once again, like I said, just stay on top of what they're currently doing out there. This is just what your book currently says. So like I said, I'm not going to hold you as detailed on this. Surgical repair usually requires a sternotomy and bypass, heart bypass. The main goal is to get a bigger right ventricular outflow tract. In other words, to get a bigger pulmonary artery opening, right? That's the whole thing. And then if they can close the VSD, if the kid's stable enough to close the VSD with a patch, that's the best. A lot of times they'll leave the foramen valve open, or even create a small ASD, right? That helps decrease pressure on the right side of the heart, right? Because the right ventricular hypertrophy. So they use that as a pressure relief. Isn't that crazy? Secondary patients might have a residual right to left shunting and systemic saturations in the 80s to 90s. Not nearly as bad as what we were seeing with the previous thing we were looking at there, where we had to keep them in the 80s, 70s to 80s with HLHS and stuff. Conduction abnormalities, very common in these kids. So that's something that we have to look at case-to-case basis. Truncus arteriosus, this is a whole separate thing. This is uncommon. It's something where you have just a single artery that comes from the ventricle. So in other words, you don't have a pulmonary artery, you don't have an aorta, you have this sort of one vessel that's trying to act as both. So the VSD you'll have here allows for a lot of mixing of the blood in the ventricles. You'll see cyanosis and systemic vascular volume overload, right? So we have only one vessel that's coming from the heart to the rest of the body and to the lungs. So systemic and pulmonary circulations are parallel. So this is where, hey, whenever you see the circulations are in parallel, that leads us to that PVR, SVR teeter-totter, right? That's what we're talking about here. Neither one of them can be out of balance, otherwise we're going to have an issue, and that's something you have to worry about with this as well. Pulmonary blood flow is usually higher, threefold higher than systemic blood flow with pulmonary overcirculation. So that causes a lot of workload on the heart. That means the heart has an increased VO2, and then we're going to have a decreased metabolic reserve. In other words, this baby can go into a lactic acidosis very easily and then go into a combined or mixed acidosis and shut down organs and all that stuff. Crazy stuff. I love these pictures. We put those in here, but you can see how there's just one vessel that comes off of the heart here, and that's what we're looking at here. The right and left pulmonary artery. So on the picture on your right here, you'll see the left pulmonary artery and the right pulmonary artery coming off of this vessel, and then here you're supposed to be your aortic arch, right? So you see that blood is just flowing, and then tricuspid valve, right? You see that blood is just flowing into this one vessel through that VSD, one vessel, and then it's just sort of deciding which path it wants to go. If you have high systemic vascular resistance, then it's going to go to the pulmonary. If you have high pulmonary vascular resistance, it's going to go to systemic. So this is what the balance that we have to look at here. The picture on your left, you sort of see the same thing. You'll see that right ventricle lead into, and then they have that VSD. So you'll see that that leads into just one giant vessel there. It's pretty crazy. So blood goes through that truncal valve, right? So they don't have a pulmonary or aortic valve, just that truncal valve, and then it goes into this common area where it has to sort of decide which area it's going to flow, to the lungs or to the rest of the body, right? So that's that balance between the PVR and SVR you got to watch out for. So if my pulmonary vascular resistance drops, right? So if I give a pulmonary vasodilator, or the baby's breathing more negative pressure breaths, or anything like that's happening, they're going to have a lower blood pressure, right? Because then the path of least resistance is the lungs, and it's no longer going to want to go through to the arterial, to the systemic circulation. But if SVR decreases for some reason, like we give a vasodilator, more blood will flow to the body. In other words, we'll have improved blood pressure in this case. However, you are sort of robbing Peter to pay Paul. I know that's a weird saying, but when you're doing that, their blood pressure will get better, but how much blood is going to their lungs to pick up oxygen, right? So you're not getting near as much blood to pick up oxygen on these patients. So you have a chance of developing hypoxemia there as well. Whew. So is it acyanotic or cyanotic? Well, you should know enough by now. Let me know. This is what we're looking at here. This is the animated drawing, of course. You can see that VSD go into that one common area, and then it has to decide from there if it's going to go pulmonary up here, or if it's going to go aorta down there. So this is what we have to worry about here. Remember, the biggest thing to remember with some of these conditions, if it's one of those ones that you have to have, that I use the teeter-totter balance thing, but you have to have that balance between PVR and SVR. And be prepared. You should know what improves PVR. You should know what is not good for PVR. You should know what improves SVR. You should know what is not good for SVR, right? Those will help you at the bedside. So signs and symptoms here. Chest x-ray has a large heart, so cardiomegaly. So obviously you would see aortic arch, obviously, in this situation. Is that going to be specific to this one thing? No, right? A lot of these babies are going to have pulmonary blood flow that may increase as PVR drops, which may be that this kid has signs of like a CHF. Remember those congestive heart failure patients that come into the emergency department with pulmonary edema? Because well, in that case, it's cardiogenic pulmonary edema. In this case, it's still pulmonary edema, but it's from more blood volume that's going there. Well, same thing with CHF, more blood volume that's in the lungs, because not blood is backing up. It's not being squeezed efficiently out of the left ventricle. So a lot of times their cyanosis is not apparent until late on. Patients usually require intubation and ventilation because of their hemodynamics. So you got to understand that hemodynamics can be very tenuous in these babies. The goal of the gas, guess what, is returning, that was seen in HLHS, is the rule of 40s. I want you to know that. 40 and 40. Extreme care, remember, oxygen-induced pulmonary vasodilation may drop blood pressure, right? And they might go into shock. So, titrating FiO2s up, be very gentle, baby steps. The more sick the patient is, the more small your steps should be. All right, diagnosing, echo is going to be your best one here. They can use x-ray, non-specific, EKG, MRI, cardiac cath can all be used. Cardiac cath would also be a very good one here. However, that would require anesthesia usually. Treatment, palliative pulmonary artery banding is a good idea here. That's our way of increasing PVR so they have good blood pressure. It stabilizes the blood pressure until they can get surgical repair or stable enough for surgical repair. Once they do that, they can do surgical repair where they close the VSD. And then obviously they'll be on a vent for a little bit afterwards. But you got to be careful about pulmonary hypertensive crisis and low cardiac output system here going on. So you might have to balance that PVR, SVR as the care team on the bedside. Transposition of the great arteries is exactly what it sounds like. It's one of the most common heart defects. This is where the aorta and the pulmonary artery are reversed. I know, it's like the Sadie Hawkins of heart. Well, you just ignore that. But aorta is arising from the right ventricle, and the pulmonary artery is coming from the left ventricle. So obviously the two circulations, guess what? Are in parallel rather than in series with each other. So the survival rate currently is very good on these kids. And so this is just a cath lab of what you're looking at here. So they're just connected to the opposite sides they're supposed to be. So you have deoxygenated systemic venous blood that goes through the right side of the heart and to the body without flowing through the lungs. You have deoxygenated blood going through the right side of the heart that bypasses the lungs. So that means in order for us to get any oxygen to the rest of the body, we got to have that ductus arteriosus open. So this sounds like it is a ductal dependent situation, right? So this is a ductal dependent situation, right? So that pulmonary venous blood flow passes through the left side of the heart back to the lungs without flowing to the body. So we have good blood that's coming from our lungs. So oxygenated pulmonary venous blood goes to the left side of the heart just like it normally should, but it goes back to the lungs again. Well, it already picked up the oxygen. It already got rid of its CO2. So it's just in its own circulation. It's just going from the lungs to the heart, back to the lungs, back to the heart, back to the lungs, back to the heart. And then same thing here. We have venous blood flow going to the heart and then to the rest of the body, and then venous blood flow to the heart and the rest of the body. It does not go to the lungs. So you see how they said it's in parallel? So the survival is dependent on making sure that that ductus is open, because that's the only communication between the pulmonary artery and the aorta, right? So the best way to do this would be to make sure that that ductus arteriosus is open, so that oxygenated blood that's going to the right side of the heart is also going through the ductus arteriosus, which is then going through systemic circulation. Right? So we need that open, right? So we need that mixing of blood in order for survivability here. A lot of times ASDs, VSDs, or PDAs are great sites for mixing as well. But mixing at one or more points is going to be a big thing here with TGA. So, or TGA or TGB, same thing. Right ventricle is usually hypertrophied, right? Because there's a lot of pressure on the right side. And then the right cavity is often hypoplastic with TGA. So obviously the left side of the heart receives blood from the left side via ASD or PFO, and then that would be then pumped through the body ultimately. So this is a ductal dependent. You tell me if this is cyanotic or acyanotic. All right, this is what we're looking at here. Obviously, if we don't have this communication over here between the aorta, not the aorta, the atriums, the right and left atriums, that's going to be very hard because we're not going to be able to mix that blood. And same thing with the ductus arteriosus. We're not going to be able to mix that blood. So we need those two communications. We need either a PFO or an ASD. We need that to be open as well as the ductus arteriosus. Whew, I hope you got your fetal heart circulation shunts down by now. Been talking about it for quite a while. Signs and symptoms of a TGA, TGB. Cyanosis, the main sign is cyanosis. That is not responsive to oxygen. You can give them 100%. or 1.00 if you're doing FiO2, you can give them a lot of oxygen. You're not going to see their cyanosis change. Things that you might see on their x-ray, eggs on a string appearance, you can look up some of those x-rays that are out there. Obviously, you need to have mixing of blood. So you need an ASD or a VSD or a PFO. You need something like that on these kids. A lot of these kids usually will require mechanical ventilation, so get ready to do that. These guys are dependent upon their ductus staying open. So prostaglandin E1, which is the prostaglandin that maintains patency. This is the prostaglandin that is secreted by the placenta, right? So you're trying to trick it to thinking it's still in fetal circulation, so that way it stays open. So that's going to be started immediately, as much as you can to maintain patency. If there's more hypoxemia going on, obviously you might have inadequate atrial mixing, so they might have to then add a balloon septostomy. In other words, open a communication between the atrias even more. Obviously, they can do this at bedside if they need to. That might have to be done early. Cardiac cath lab is an option here. Obviously, this is something that can be an emergency, of course. All right, infants with this, they might have early cyanosis, acidosis, so we need to keep those shunts open. If they have a large VSD, they might be mild initially, so that VSD is actually helping that kid if they come out with a VSD. Usually, they'll be a lot less cyanotic with stress, more cyanotic with stress or crying. That shunts even more blood because it increases SVR. So a loud heart sound can be heard on these babies as well. So treatment, prostaglandins, I just told you about this one in the previous screen. Prostaglandins is going to be the most necessary one to keep the ductus arteriosus open, right? So obviously they'll be on the ventilator. They can have a lot of apnea episodes because that prostaglandin is telling their system, hey, you are still connected to a placenta. You don't need to breathe, right? Because the placenta is doing the work. They'll probably need to be on the ventilator because their body thinks that they don't need to breathe yet. Atrial switch operation is what would be performed where they switch the atria in the pulmonary artery, of course, and that's usually done within the first 2 weeks. It's crazy. So that's a general heart surgery. They have to go through the sternum. That's pretty crazy. And you can read the rest of it here. Like I said, I'm not going to hold you in detail. Here you should know the basics of the different types of therapies, but I want you to focus more on the physiology, right? Postoperative issues here include a low cardiac output and a lot of ECG disturbances, yeah. So they will be very unstable there. So the big thing here is looking at their perfusion, ST changes on their ECG. You can see those on these kids. So part of the atrial switch operation usually makes them have to re-implant the coronary arteries as well, and so they can have spasms there, and seriously, those spasms can cause those ST changes, which, as you of course know, can lead to, especially if there's arterial spasm, can lead to heart failure and decreased myocardial blood flow nutrition. Obviously, those aren't great. So these kids are very tenuous. Oxygen therapy, got to be careful with it here. You should be kept near PO2 and CO2 should be 40 and 40. So does this sound familiar? 40 and 40, and they're probably in the 70s. For your saturation goals. So that's what you're looking at here. So 70s to 80s, just like your hypoplastic left heart syndrome, somewhere in that area, and then you're using your 40 for 40 protocol, right? So right ventricular hypoplasia, usually thought to be catheter candidates, right? So that's something that they'll have to look at from a case-to-case basis. Right, and this is what they're doing with the atrial switch operation. They're going to put bypasses in there. There's lots of good videos out there on this as well. All right, so real quick, this is just with congenital heart defects. So those are all the congenital heart defects that I just wanted to tap on a little bit there. There's much more than what I was able to cover there. But when you're looking at this pulse oximetry with a heart defect, you're looking at systemic oxygenation usually, especially if it's post-ductal. So you can look at how bad the shunt is in different lesions. Usually that 5 to 10% lower from pre to post-ductal indicates that they're shunting, right to left shunting. So not only can we use it to see if there is a shunt, but we could also use it to sort of see how significant the shunt is as well. Right, bigger gradient, bigger shunting is going on. So low saturations, less than 80% pulse oximetry gets variable depending on the manufacturer out there. Some of them are like, ours will go down to 70%, right? So the lower the saturation, the less accurate it's going to read. So just understand that. Newer pulse oxes have a lot more reliability at lower saturation, so you're in the right age now. Other things that can contribute include things like they gave methylene blue, so that would be if they had nitrous oxide exposure, so that NO2, which caused methemoglobinemia, which the treatment for methemoglobinemia, of course, you're like, Derek, I know the treatment for that would be methylene blue. Excessive ambient light, patient motion. Remember lidocaine. Lidocaine can even cause methemoglobinemia, so if they're using lidocaine on babies for some reason or another, that could also cause that as well. Capnography, of course, I'm a big fan. Can you sign this for me? Should be used in all mechanically ventilated children with congenital heart disease. So that's a general statement. Just pay attention to the facility you're working at. I think it's a good idea, but that's me. I'm a nerd when it comes to end-tidal CO2 and how amazing it is in a lot of stuff, because it gives you perfusion as well. A congenital heart defect, do you want to know about their pulmonary perfusion? Yes, especially if they have parallel circulations where you have to balance PVR and SVR. Hopefully you just understood what I said there, right? End-tidal CO2 correlates well with PaCO2 in a lot of cases. Normal gradients around 2 to 5. Therefore, so if you have an increase in this gradient, and this is a good thing if you have trouble with this for some reason, this is a good thing to like shrink and put on the back of your badge or something like that. When you're looking at this, what causes end-tidal to go up? Well, increase in dead space ventilation, so that means poor perfusion, lower pulmonary blood flow, poor perfusion, high airway pressures, like mean airway pressures, like alveolar overdistension. In other words, their compliance got better, but now you're using too much mean airway pressure, right? You're overdistending everything. Pulmonary embolism, easily. End-tidal CO2, if it's going down, this could be caused by, hey, guess what happened to the ET tube? It either got dislodged or obstructed. Air trapping, you'll see that in your COPDers where you have that shark fin instead of that nice plateau. Remember, the plateau is alveolar ventilation. You don't get that in like asthma or, someone that's air trapping. Decreased pulmonary blood flow, of course, right? Because then you have less CO2 going there. Low cardiac output, of course. It sounds important. And hyperventilation, of course. So if their minute ventilation has changed, then obviously you would want to see that end-tidal go down. Elevated CO2 usually indicates hypoventilation. In other words, something's going on. If they're in pressure ventilation and their end-tidal CO2 starts to go up, what happened with their compliance? Well, their compliance started going down, right? So they're hypoventilating. They're developing a fever, right? Remember, that's a metabolic rate thing that would increase it. Or even things like malignant hyperthermia if they were given a paralytic like a succinylcholine. These are all things to look out for. You can use it immediately after intubation to confirm placement. You can see ventilation real time, especially perfusion as well. And you can look at CPR, return of spontaneous circulation, and then even kids with a different type of shunt, you can see that it might indicate something like a loss of pulmonary blood flow. Pretty crazy, or they developed a thrombus of some sort. So there's a lot of value here is my ultimate bullet point. You can use end-tidal CO2. I'm a big fan of it, but I recommend that you guys be the end-tidal CO2 nerd wherever you're working. Understand what it means if it's high, understand what it means if it's low, and what would you do about it, because otherwise it's going to be useless that you put it in line. If you don't know what it means, and you don't know how to troubleshoot with it, right? How are you going to use it? Then, that's something that I would recommend. Of course, you're going to love it a lot more once you know what it means. All right, cardiac output. You can directly measure different types of things. Direct cardiac output measurements are using an invasive catheter, and usually it does a dilution technique. You can calculate it, of course. There are lots of stuff out there that calculates it for you. Even calorimetry can do that in some cases. You can use central venous pressure pulse ox to look at heart disease or low cardiac output with kids. So you can see that changes there. SVO2, venous saturation. That's something that we even use with sepsis on our adult ICU patients as well. Echo obviously can be used to estimate cardiac output. That's usually a very quick bedside thing, non-invasive. I love that option. Other important surrogates for cardiac output monitor include looking at serum lactate. If their lactate's increasing, that's a sign they don't have as much perfusion to their body, right? Their urine output's decreasing, their perfusion to their body is decreasing. Their neurological status is changing or decreasing, right, poorly, then that's a sign that that's a low cardiac output. All right, ventilation management. A big thing here is you got to be an expert with hemodynamics and positive pressure ventilation. I just talked about that a little bit a while ago with, hey, what happens to your thoracic cage with positive pressure ventilation? What happens to your vena cava? What happens to your atria? Now what happens when you're doing spontaneous breathing, right? That's going to be the big thing there. All right, so you got to know that if you increase intrathoracic pressure, right, with positive pressure, it will decrease systemic venous return to the right atrium. We're decreasing preload, which decreases cardiac output by diminishing how much is going in there. So patients that have anastomosis, like a Glennon or Fontaine surgeries, where blood flow is passive, well, that pressure might actually cause decreased pulmonary blood flow. Right, because remember, they don't have that right atrium, right ventricle to send it to the lungs now. We bypass the right side of the heart. So on these kids, in this situation, early extubation to physiological negative thoracic pressure, in other words, extubating them to where they're breathing with negative pressure ventilation, so spontaneous breathing, is going to improve their hemodynamics. So that may include using spontaneous ventilator modes, or modes that rely more on spontaneous breathing. So obviously timing extubations are going to be big. Here, it's going to be a care team decision. You're going to have to look at cardiac function overall. Is their heart healthy enough? Is their heart not healthy enough? There's a lot of variables in here. So that's this whole care team decision. In effect, interventions that affect PVR. So this is another thing that would go great on the back of your badge as a new grad. Increases if you have someone that has an acidosis. So let's say you draw blood gas on an adult critical care patient and they have a 6.9 pH. Do they have a high pulmonary vascular resistance? Absolutely. Are they going to be able to oxygenate well? Absolutely not. That's why you would use something like nitric oxide or high FiO2s, right? That's what we're talking about here. So this works neonate through adult. Things that would increase pulmonary vascular resistance, acidosis, low minute ventilation, right? We're talking about alveolar minute ventilation. I can have someone that has ARDS or asthma, and I can give them, as an adult, a minute ventilation of 18 liters a minute. Normal is 5 to 10 liters per minute for an adult. I can give them 18 liters a minute, but if their alveolar ventilation is poor, if their alveolar ventilation, how much is getting to the respiratory zone, is less than 4 liters a minute, then we're still going to have hypercarbia, right? So that's what we're going to be looking at there. So low minute ventilation, of course, and alveolar minute ventilation, so effective ventilation. Increased CO2, decreased pH, of course. Low FiO2s, right? That's what we talked about, the hypoxic gas therapy when we were talking about those kids trying to keep their shunts open. Increased mean airway pressure, of course, right? Because that's high thoracic pressure. So that means, what are factors that go into increased mean airway pressure? And I included it right here, right? If you have a higher peak inspiratory pressure, a higher PEEP, a higher frequency, or higher I to E ratio, let's say you go from a 1 to 2 to a 1 to 1, that will increase your mean airway pressure. So there you go. I included a whole list for you. You're welcome. Things that will decrease, of course, alkalosis, right? That will help decrease the pulmonary vascular resistance. High alveolar ventilation, so volumetric CO2. I love volumetric CO2, but I'm just happy if we give regular entitled. Higher FiO2s, of course, that's like one of the treatments for pulmonary hypertension is just give them some oxygen, right? A low mean airway pressure, of course, that will help avoid restriction on the aorta. Not the aorta, the IVC and the SVC, as well as the atria. The atria is what I was thinking. And then we can also give drugs, obviously, PG1, nitric oxides, and even prostacyclins. CO2, I talked about this earlier in there if we want to do hypoxic gas on some of these kids, and also help increase PVR if we needed to, if they were dependent on their PVR being higher than their SVR. So it might help adding that to inhaled gas, hypercarbic therapy. So usually they'll use 2 to 5% CO2 mixed with the gas to get them to that target saturations. It should be 85, 75 to 85%. Adding CO2 should help the patient increase their drive to breathe as well. And usually patients are intubated, heavily sedated under neuromuscular blockade when we're doing this. So you're adding a modified oxygen air mixer. Modified is the key word there. You're using an air oxygen proportioning device is what the boards will tell you. It's a blender, right? That'll bleed CO2 into the circuit, and then that's going to help you with managing that kid. And you're going to use a capnometer, right? It's a way to actually measure how much CO2 because this can be very dangerous if you put too much in there. This is what you're going to do here. Normally the air inlet that you would use would still be hooked up to the air inlet, but instead of hooking up an oxygen tubing and an oxygen to the oxygen inlet, you're going to get a giant nitrogen tank, and those are so this is using nitrogen instead of CO2. And you're going, they're black. They're black tanks. So remember the color coding of the tanks. Nitrogen is black. Okay, so you're gonna hook up a hose. Here's your manometer, and you're gonna hook up a hose to the oxygen inlet. And that even though it's oxygen inlet, it'll still fit. It's not the diameter index system. All right, so when we're looking at this, you hook that in there, and then the ventilator is the air inlet is connected to the blender. The oxygen inlet's connected to an oxygen wall source. So that's still connected to the oxygen wall source. So you're going to use the blended gas here. And then ultimately you're going to, when the breath is being delivered to the patient, you're going to want to put an oxygen analyzer in line. The idea here is you want around 17 to 18% if you're doing hypoxic gas therapy to keep those shunts open for those ductally dependent kids. All right, so quick summary. Pulmonary vascular resistance may be altered by changes in pH, right? In oxygenation and mean airway pressure. This is a good life lesson in respiratory therapy, right? That's a universal truth. This is a universal truth. You're like, Derek's universal truth of the day, right? If I had fortune cookies, this would be one of the things in there. Hey, PVR is altered by pH, oxygenation, mean airway pressure, right? Neonate through adult, universal truth, all right? Positive pressure ventilation may negatively affect pulmonary blood flow or cardiac output. That's also a universal truth, right? Universal truth there, right? So in kids with heart defects, we got to look at that. How much positive pressure is really affecting those kids and weigh the risks and benefits of extubating them sooner or later. We need to heed the hemodynamics. In other words, pay attention to the hemodynamics and get to know the normal values. You need to pay attention to what the goal values are for these guys. Big thing is to be aware of what the patient's responding to and communicate with the care team, right? This is not you walking into a room, writing down numbers and walking out. You are more than that. You've been trained better. So hopefully these things sort of summarize things for you. I know I sort of spoke fast, but I want you to sort of understand that there's a lot of complications here, communicating, understanding the physiology, and of course you'll be more comfortable with this the more you're exposed to these conditions out there. And if you have any questions, just let me know.